Sydney, do you want to get started with yours?
Yeah, did you say my name?
Yeah.
Yes. Yeah, I would love to if you want to share your screen. It was showing me like I was having issues with my privacy settings because it's being recorded. So, anyways, I think it's just easier if you can share the screen.
Sure, you got it.
Thank you.
All right, the time is now 9:10, and as you guys can see, we've got lots to go through, so we'll get started with Sydney.
Okay, so can I go ahead and start? Is that okay?
Sure.
Okay. So I'm going to be talking to you guys about throat cultures and like how to collect them. We do this a lot in the ED. If you guys have probably already done this before, and if you haven't, you've probably done like a COVID swab, which is really similar, just going through the nose instead of the mouth. If you want to hit next, Karina, yeah, and then next slide, and then next again. Sorry. So cultures are used to detect a bacterial infection, and I believe they can also be used for like fungal infections. The most common one that we'll do in the ED is for strep or for strep. So we're looking for the group A streptococcus bacteria. You want to hit next again, Karina. So once we get these culture results back, this will help the doctor determine the best course of treatment for this patient and also determine what antibiotics they're going to be on. So how to collect the actual swab. First, you want to start by like setting up your work surface area. Make sure you have the space to do it. Do you want to hit next, Karina? So sorry. Make sure you wash your hands, put your gloves on, all that. Then you want to have the patient open their mouth and have them say "ah." When they say "ah," that's going to like naturally depress their tongue a little bit. Then as they're saying "ah," you can use the wooden tongue depressor to further depress their tongue. And then you want to swab. It's just like a long Q-tip. Like you want to swab the back of their pharyngeal wall and like where their tonsils are. So I thought this picture showed that really well. And then you just want to be careful when you are swabbing and when you're pulling it out of the mouth. Make sure you don't touch like their cheek or teeth or tongue or anything that could contaminate the culture. And then when you're done, you just put it in the little plastic tube that it came in. Make sure you label it with your patient identifiers, scan it and collect it in the computer. And then afterwards, we're waiting for the cultures to result. So it usually takes like 24 to 48 hours for the cultures to come back. They do this a lot in the ER and like in urgent cares. They can do like a rapid strep, which can come back in like 10 or 20 minutes. But yeah, you pretty much just wait for the results to come back. And then if it's positive, then the doctor will determine what kind of antibiotics a patient needs to be on. And yeah, those are my references. So that's all I have for you guys.
All right, awesome job. Thank you very much. Ellie, are you able to go next?
Yes, let me try to share my screen.
Oops, I'm going to stop share. There we go.
Okay, I haven't done this before, so where is it again? Is it down on the bottom? Oh, share screen.
And we can see your screen now.
Do you see, here, let me open up the PowerPoint. Okay, can you see the PowerPoint then?
Yes.
Okay, so I had delivery kit, also known as emergency obstetric kit or precipitous delivery kit. These help deliver babies in emergency situations. They improve the survival of both mom and baby. They can be used in emergency rooms, in the ambulance, at home births, and they usually come pre-packaged. So each kit varies as far as what is in it, but should have an underpad or a chucks, and it's probably a good idea to grab extra of these if you're in the emergency department. It should come with 2 sterile umbilical cord clamps. You clip those on the umbilical cord and then cut in between them. Either with a sterile disposable scalpel that's provided or the sterile scissors. It should be one or two of those. There should be a sterile bulb aspirator, which is used to suction the baby's nose and the mouth for any fluids or sign of respiratory distress after delivery. There should be a clear plastic bag for the collection of the placenta or placenta bag. Sterile exam gloves. There should be an OB antiseptic towelettes to clean the perineum, or sometimes they have sponges that you would use like when scrubbing in for surgery. They have gauze in there, and if not, might be a good idea to grab some if in the emergency department, just to collect any blood or any other fluids, or use to apply pressure after the delivery. There should be a sterile obstetrical pad or maternity pad, which is placed on the patient's perineum after the delivery. There should also be a biohazard bag included in the kit to clean up waste if you're not in an emergency department and you're at home or in the ambulance. And then there should be a drape or 2 receiving blankets that you would place on the mother's stomach and the chest that you would place the baby on once the baby's born if they're stable. And then if you're in the emergency department, it's probably a good idea to grab the neonatal warmer and resuscitation equipment if you have it, and to page OB or PEDS depending on the hospital. And then some questions that would be a good idea to ask are, what is their gestational age, and a quick OB-GYN history. So if they have any history of shoulder dystocia or C-section or anything like that, that would probably be good information for them to know. And that's it.
All right, Allie, thank you very much. We prefer not to deliver babies down in the ER, but it happens from time to time. Bailey, are you able to go next?
Yeah.
I don't know if I caught you, so I'm gonna try to make you, I'm looking for you on my Zoom, trying to make you a host. Oh, you got it.
Yeah. Can you see?
Yes.
Okay. Okay, so I had tourniquets. What is it? I'm sure we all know, but I'll remind you, a tourniquet has 2 main uses. It can be used to apply pressure to a limb or extremity in order to control or stop the flow of bleeding in situations like emergencies, surgery, or post-operative rehabilitation. And it is also used by a phlebotomist, nurse, or other specialties to assess and determine the location of good venipuncture. So overall, it helps to constrict blood flow, and they can be manufactured or made from everyday objects. So in emergency, first, it's important to remember that a tourniquet can be placed around a limb for, it should not be placed around a limb for an extended period of time, and that it's a temporary fix. They should not be placed for any longer than 2 hours, because after this time frame, there's an increased risk of permanent ischemic damage to muscles, nerves, and blood vessels. Muscle damage is complete around the 6th hour mark, which is soon followed by limb loss and amputation, which is what we want to avoid. There are special tourniquet devices that can be used, such as this one over here. But when you do have little resources available, a tourniquet can also be made from a stick and a cut piece of cloth. And this was my best way to put into words what you do, but you tie the cloth around the limb as tightly as possible, tie the stick down to the patient as well, securing it within the cloth, give as many twists as possible to constrict the limb until the bleeding ceases, and secure the stick in place so it doesn't unravel. Belts, rope, and seat belts can also be used to do this. And then for vein puncture, medical staff use small elastic tourniquets routinely to help with IV placement. It's important to avoid constricting blood flow to a greater degree than is necessary to identify a suitable vein. For placement, a tourniquet for IV insertion can be tied above the anticipated injection site. The tourniquet should be tight enough to temporarily stop blood flow in order for access to become more visible. The patient can then make a fist, pumping their hand to further help with the identification of veins, and the tourniquet should be removed immediately after vein access is retrieved. Do not forget to remove the tourniquet, as you can lead to ischemia, which I have been guilty of doing, so don't do that. And those are some of my references.
All right, great, thank you. Madeline, you are up.
Sure. Can I share screen?
Yep.
Yes.
I'm like kind of stuck. If you can mute me, Karina.
Okay, so it's on there?
Yes, we can see that.
Okay. All right. So lateral canthotomy. I'm gonna give a big warning. This stuff is really, really gross. So like, if you need to like cover up your screen because it's just like, it's really gross. Let me, one sec. How do I? Sorry. Okay, yeah. Is it showing the full PowerPoint or is it like showing my notes too?
It's showing your notes as well.
Okay, gotcha. Okay. Sorry. How do I?
The upper left, yep, from the beginning, it'll.
Okay, all right. And is it good now?
It's perfect.
Okay, all right. So just some background, orbital compartment syndrome is major edema of the eye. It is where you have greater intraocular pressure than pressure at the ophthalmic artery. It's an emergency. It can cause blindness within 2 hours, and the major causes are trauma and surgery. So the treatment for this, though, is a lateral canthotomy, which is a surgical excision of the lateral canthal tendon, which is like just the tendon holding it on the lateral portion. So like how they do it, and this is done by ophtho or ED. They sedate so we sedate them if we have time. We prepare the skin with beta-hexene. The provider injects a local anesthetic. They rinse the area with saline. They then clamp the lower eyelid for like a minute to like reduce like swelling or bleeding and swelling. And then they like cut in there with iris scissors. They cut about like 1 to 2 centimeters. Once they do that, they identify the tendon and sever the lower branch in order to like relieve that swelling. After about a minute, they recheck the intraocular pressure and then sever the upper branch if they need. It is, I took out like the really gross photos. Yeah. So then the nurse's role in this is to assist and provide help if need be. We give and get the meds, like the sedative, the Lido with epi, pain meds if they need, also post-op antibiotics and steroids. We put a sterile dressing on because the patient's not going to be able to blink afterwards. Of course, they're being admitted, and we provide education on like no straining, apply ice packs, and it actually heals on its own, which I thought was pretty interesting. The picture in here is like 2 weeks afterwards, and like I can't even tell really anything's wrong. And yeah, so here's some references. It was pretty short.
Madeline, I love this. I have to admit, I did this for my own fun. But, we had a patient quite a few years ago down in the ER, and they were in need of a lateral canthotomy, and the ophthalmologist wasn't available. So the absolute cowboys, the providers are. One of our providers got onto YouTube and he knew what he was doing, and then we
You're like, oh, it's just pretty easy. Yeah, I could do that.
And then we proceeded to do the lateral canthotomy. So I just thought that was fun. So I've only seen one. It's just-
Yeah, I've never seen one before, and like I think Dr. Wolfer tricked me into looking it up, and I was horrified.
so he was equally as astounded at that.
Yeah.
All right, good job. All
The
right.
look up on YouTube and do the procedure is the horrible thing. Is the thing that scares me.
We
It couldn't
just
be that
love
hard.
laughing. Yeah, I had a patient with LVAD, and I was like, well, how am I going to do their blood pressure? And you could actually do it with a Doppler. So I looked it up. I looked it up on YouTube University as well. So it's amazing what's all in there. So all right, Laura, you're next.
Alrighty, give me just 1 second because it decided to be fun when I was opening it. Okay, is it showing up for you guys?
It sure is.
Perfect. So I had paracentesis. This one's actually not too bad, although it can refer to the eye. Thankfully, that's not what this one's for. This is just what we're going over. What is it? Why are we performing it? And what's the nurse's role before, during, and after? Kind of just comes down to assessment. So paracentesis is when we're going to be removing fluid from ascites from the peritoneal cavity. And there can be a lot. They kind of like daisy chain up all of these different suction tubes or these light bulb looking tubes like Plerex drains. But we are going to drain the ascites either to diagnose the cause of it. It's going to be from infection, can be from cancer or other chronic conditions, sometimes heart failure, or there was a condition with the lungs, but I wasn't quite well aware of what it was because it was very smart. That was way too smart for me. But it can cause difficulty breathing, pain, and it can help to relieve some pressure that's like on the organs. It can kind of like put pressure on the portal veins or on the aorta or the inferior vena cava, and it can kind of cause some issues there. So before the procedure, this is just one of the different setups. This is for a setup that's going to be like you don't have a permanent drain in. But we're going to be obtaining informed consent because it is considered an invasive procedure. We're going to get some vital signs because there can be a risk of fluid shift if we have to take out a lot of this fluid, and we kind of want to keep an eye on that blood pressure and heart rate especially. We're also going to be assessing cardiac, respiratory, GI, GU, and lab results just to kind of figure out how things are going. Cardiac to make sure that nothing's being compressed too much, even though the fluid's like more down in the abdomen. Respiratory just to assess their work in breathing. GI and GU because there is the risk of puncturing like the stomach or the bladder or the intestines when you're going in to drain. And you're also going to be checking lab results like electrolytes. And we'll just grab our little supply of kits. It kind of depends on facility policy or if they have a permanent drain in, if kind of what supplies you need. Most of the time you just need some type of needle, something to clean with, something to drain with, and preferably some lidocaine. And they like Lido with epi just because it helps to prevent so much bleeding. So during the drainage, this is one of those long-term catheters we've been talking about. I actually got to see one of these and I got to see that kind of stuff drain out. It was very interesting. So you're just going to be assessing the abdomen and its appearance throughout. You're going to be checking the girth before and after, especially, just to see how well the draining has worked. During, we're going to be monitoring the vital signs. How are we doing with pain? Did we puncture something? How's the heart rate happening? Is our blood pressure stable, and is our oxygen saturation increasing, decreasing? What's going on with this? We're also going to be assessing how much is draining, the rate of flow, and the characteristics of the drainage. We're really going to be starting to watch around, I think it was a 5-liter mark, and it's considered a mass drainage. Excuse me, I'm sorry. And we can get some problems with our vital signs, and they can kind of have that vasovagal response and pass out, and some other things can happen. So after the procedure, you can kind of see this person had the ascites drained from them, and it's just a huge difference. This person actually had a permanent catheter put in. I don't know if you can actually see my mouse or not, but this person had a permanent catheter put in, and this is just after one drainage session. But after the procedure, you're going to apply pressure for at least 5 minutes, and you're just kind of like be checking for flow, kind of like after you remove an art line. If it continues to flow even after putting pressure, I think the longest I saw was 20 minutes. Suturing of the site may be required just because it's just not going to stop leaking on its own. If you're going to be testing the specimen, you're going to be labeling and transporting, you're going to be documenting the amount and characteristics of the fluid, obtaining new vital signs, and you're going to be doing this pretty frequently. Think of it like post-surgical vital signs, because I think I had notes, but they're covered up. It's like 2 sets of 15, 2 sets of 30, 4 sets of every hour, and then you can go, I think, to every 4 hours. You're going to be reassessing cardiac, respiratory, GI, GU, and labs just to make sure nothing was punctured or messed up in the back. Sorry for the background noise. Or, what's my train of thought? So nothing was punctured and that your electrolytes are still stable and that fluid shifts have not occurred. You're also going to be monitoring the site because infection is a huge risk with this because the peritoneal cavity is considered a sterile space. And these are just some of the sources. They have a wonderful little YouTube video that goes through all of this.
All right, outstanding job, Laura. We really appreciate that. And I think your bird is a little bit jealous that he wasn't getting all the attention there.
Oh yeah, he got relegated into the cage. He's not thrilled.
All right, Logan, you are up next.
Okay, give me a second to figure out how to use this. Okay. Alrighty, can everybody see my screen here?
Yes, we can.
Here we go. Obviously, I did not play through this before I started presenting, so. Alrighty, and it went to full screen for everybody?
Yep, we can see that full screen. We can see what you're seeing.
Okay, sounds good. So Laura did the paracentesis, my presentation's on a thoracentesis, and mine is not very long, nor is it as pretty as Laura's presentation. So we'll see how long I can talk about this. So just first off, we're going to talk about what it is. If you don't already know what this is, a thoracentesis is an insertion of the needle into the pleural space. And you're going to do this to remove any air or fluid that's in the pleural space. It's usually used to treat pleural effusion. So that's a buildup of fluid in that pleural space. And we just take that off with this needle. It could be used for diagnostics. So when you pull that fluid out, you could send some of that fluid for analysis in the lab, looking for any infections, maybe cancer, pancreatitis, empyema, liver failure, tuberculosis, and pneumonia. So that's just interesting to note. I put the signs and symptoms of pleural effusion because when I was going over the research, that was the most common cause for having this done. So you'll see chest pain, you'll see a dry, non-productive cough, difficulty breathing, and then orthopnea. So risks of this procedure, there's the risk of the entrance of air into the pleural space that could cause a pneumothorax during the procedure. So that's something you want to watch for. You also want to watch for bleeding, infection if the sterile procedure is, if you break sterility, you could cause an infection in that space. So it's really important to stay sterile during the procedure. And then also injury to underlying organs. I mean, you're going in with a large bore needle into the chest cavity, so you just need to make sure you're not poking anything. So this is the nurse's role. So before procedure, we're gonna obtain consent, make sure it's in the chart. Obviously, if this was done in an emergency type situation and they're not conscious or something like that, we don't have to go through that. We're gonna do the life-saving procedure. We're going to tell the patient, that they're going to feel a little bit of discomfort, maybe pressure when the needle's inserted, which is obvious. I think you're putting a pretty big needle into their chest cavity, so I think that goes without saying. But just making sure you're telling the patient that. You're going to assess for allergies to any local anesthetics. So when before they insert the needle, they usually numb you up with some lidocaine that comes in the thoracentesis tray. So you just need to make sure that they're not allergic to that, because obviously you don't want to use that if that's the case. You're going to gather the supplies for the sterile thoracentesis tray, and I don't have a picture of it, but I know what's in it. It's going to come with all your equipment that you're going to need for the procedure. So your lidocaine, it's going to come with the sterilizing agent. It's going to come with your syringes, all that good stuff. We're going to help position the patient and ensure that they stay still. So for the procedure, usually you're going to have them sit on the side of the bed, sitting straight up on the side of the bed. And that's how the MD is going to insert the needle, is they're going to be in that position. You're going to make sure that they're staying still because, like I said earlier, there's a lot of organs in the chest cavity and you don't want them to move around too much and you poke something you're not supposed to, or you don't get into the pleural space. So you just need to make sure that they're staying still, even though it might be a little uncomfortable. And then you're also going to do your baseline assessment. So what comes to my mind is you're going to listen to their lung sounds, just so that you have a baseline to compare to post-procedure when you do your post-procedure assessment. During the procedure, you're going to monitor vitals, making sure you're not seeing signs of pneumothorax or worsening of the condition that they have already. So you're not going to see worsening dyspnea, maybe new onset of tachycardia, worsening shortness of breath, or increased chest pain during the procedure. And then, like I said, this is the most important part right here, is you just don't want that patient to move during the procedure at all. You want to keep them pretty still. Then after the procedure, you're going to apply a small sterile dressing when the needle's removed. It needs to be sterile to prevent infection, but you need to apply the sterile dressing to prevent air from getting into that pleural space. You don't want any leaks going on there. And then you're going to do your post-procedure assessment to evaluate the effectiveness. If you just took off a lot of fluid from their lungs, you're going to expect them to be breathing better. You're going to expect lung sounds to be better. But you don't really know that unless you do your pre-procedure assessment and your post-procedure assessment. And then you're going to monitor patient vital signs for several hours after the procedure, just to monitor for any complications that may have arisen from the procedure. So that is all I have to present. And I didn't include my source, but I'll tell you what it is. It's the Johns Hopkins website they have. I can probably send that in Canvas or put it in an announcement or something if you guys are interested in looking at it there. So that is all I have.
Awesome, Logan. Thank you very much. And you brought up a good point, is if they are unconscious, we do something called an informed consent, which keeps us free of hopefully liability there of being able to do the procedure. So awesome job. All right, Chandler, you are next.
Okay, so I don't have a fancy PowerPoint or anything because this is kind of a skill that we've all learned about. So mine was the fluoroscopy guided NG tube placement. So we all remember how to do a blind insertion with that, and it's tip of the nose to the earlobe to the xiphoid process, and that'll give you your approximate measurement, and you just kind of tilt their head back, you go straight in, and then when you can visualize it at the back of their throat, you have them tilt their head forward, sip water, and you go into your predefined measurement, and then you can do the auscultation where you hear the whoosh of air in their stomach, and if you hear the whoosh of air, it's probably in there, or you can aspirate gastric juices, and if you get gastric juices, then you know it's not in the lungs. And then gold standard is to confirm placement with an X-ray, and then you tape it in place and you have an NG tube. Because worst thing you can do is instill feeds or whatever into their lungs. Bad juju. So what you can do with the fluoroscopy guided, and I don't believe this is a nursing procedure. I don't see why a nurse couldn't do it because we do the blind insertion and then confirm with X-ray. But what fluoroscopy is it's essentially X-ray video. So you use a radio opaque NG tube, and they're able to watch that NG tube go down, make sure you're going down the esophagus and not the trachea. And the main benefit of this is you can have more precise placement and visualize it real time. So we use NG tubes for decompression of the stomach or for enteral feedings, because enteral is preferred to parenteral. But one thing that's really nice about fluoroscopy guided NG tube placement is you can actually bypass the stomach and go straight into the small intestine. So if you have a patient that is vomiting profusely, but we still need to get them nutrients, we can bypass the stomach, and then they can't throw up what we fed them because it's not in their stomach. Do y'all have any questions on that?
All right, Chandler, great job. The answer is it is done at within interventional radiology. That's kind of in the middle of CAD, like if you guys are aware of that area. And they use this a lot in neonates and in our little guys. If they need to, just we prefer not to do that downstairs.
See, that's wild, because I just did my preceptorship in the SCN, and lots of babies get NG tubes, and they always do the blind insertion, and none of them were even verified. I've never seen a baby with an NG tube that was verified by X-ray placement. They just go in, aspirate the gastric juices, and now we're feeding. And I'm like, oh man, that's not gold standard.
Yeah, you don't want to give all those guys gamma rays there. All right, Julia.
All right. Let's see. Can you all see the screen of my PowerPoint?
Yes.
Is it full screen or is it just showing my?
It is not
no.
full screen.
Okay. How now?
Yes.
Okay, thank you. All right, so my assigned tool of the trade was nursing roles for emergent central line placement. So this is a skill that is done by a provider, either a physician or advanced practitioner. So the nurse's role is more of assistance and setup and monitoring. So why would we want to place a central venous line in the emergency setting? There are several indications for this. It would be, of course, fluid resuscitation, which can include blood products. If we need to infuse some drugs, that would be caustic in smaller veins. So we need a bigger vein for those to prevent phlebitis or sclerosis. And central venous pressure monitoring or pulmonary artery catheter introduction. And emergency venous access due to difficult peripheral intravenous access, and transvenous pacing wire placement. So I pulled the information for the nurse's role from our textbook, The Basic Nursing, and it's on page 1524 to 1525. They list the equipment needed that we would gather before the procedure. The list is there, so sterile gloves, mask, hat, barrier gowns. I won't read through all those, but the good thing is that there's actually a checklist for this procedure that your facility should have. So you can print that checklist off and make sure that you follow that. And I actually have a copy of it later in the presentation that I pulled from where I work. So yeah, you have your equipment list, and then of course delegation. This should not be delegated because there are specialized support skills that are needed. So the nurse needs to be there monitoring the patient and responsible for assisting. There are pre-procedure assessments that we should do, obtain baseline vitals and verify that informed consent has been given and assess for allergy to tape. So here's the steps for the procedure. You're going to explain the procedure to the patient, verify informed consent, get your vitals, gather the supplies, make sure everyone's following, meticulous hand hygiene. This is a sterile procedure. So you're going to set up the sterile field and add the supplies and position the table so that it's easily accessible, and position the patient in the best position depending on where they're putting the line at, and making sure the patient's comfortable as possible. And then offer the mask, gown, and sterile gloves to the physician or the provider, and don the mask and then sterile gloves yourself, and prep the marked site with chlorhexidine, and then drape the site with a large sterile drape, exposing only the prepared skin area. And then observe while the physician performs the steps, and then apply the sterile transparent dressing over the site, and clamp the clamps on the lumen if there are clamps, and close them, and place the tape over the lumen near the ends, but not on the injection caps. And this is just to minimize movement of the catheter, so they're more secure. And remove the sterile drape and assist the patient to a comfortable position, and dispose of used supplies and equipment, and remove and dispose of mask and gloves, and perform hand hygiene. So some guidelines we want to make sure we're following when this is being done is that all patient and staff in the room should wear a mask. A health professional who's received appropriate education, like a nurse, should observe the CBC insertion to make sure that all aseptic technique is maintained. And if we see a break in sterile technique, we should stop the procedure and make sure that also all the checklists are being followed. All the items on the checklist are being followed. So here's some 5 steps to prevent central line infections. Wash hands, wear sterile gloves and hat, completely cover the patient, and avoid placing the catheter in the groin if possible, as that's a higher likely infection site. And clean the insertion site on the patient's skin with chlorhexidine, and remove catheters when they are no longer needed. So the longer they stay in, the more likely it is it could lead to an infection. So afterwards, we're going to evaluate. So look at vitals, assess the lungs, and look for any sharp chest pain or coughing. And this is, there's a high likely or high risk for pneumothorax or cardiac tamponade with this procedure. So we're also going to get a chest x-ray to verify the location, that it's in the right place, and assess the patient daily to determine if there's a continued necessity for the central venous catheter. And again, the longer it stays in, the higher likelihood for infection. Then we're going to document, so the date and time of the catheter insertion, catheter type and size, site location, assessments and interventions performed at insertion and immediately after, and patient's tolerance of the procedure, and x-ray verification of catheter placement. So here's the checklist that I found from my place that I work at St. Mary's. Central line insertion, infection prevention, and safety checklist. So I'm sure that you could, I just went on to policies and procedures and found their policy, and they had this as an attachment to that policy. So I just threw it in here. So you're gonna look at the catheter type, the insertion type or site, number of lumens, reason for insertion, and then just follow down this yes or no checklist. So there's a standardized central line cart that I'm sure will be used, and you can read through that. It's nice. There's a checklist, in my opinion, and then some guidelines to follow that is like on the back of the checklist here. Any questions?
Awesome job, Julia. I like how you put your own hospitals, or found your own hospital's policy. That was That was really good. The provider might also ask you guys to take a peek at the monitor. What they usually do is if they're beyond the, the superior vena cava, the area, and have gone into the heart, the patient usually will have some kind of odd arrhythmia, like a ventricular tachycardia. So then they know that they've gone just a little too far and they need to back off just a little bit. So just make sure that you're monitoring the heart as well. Awesome.
Okay. I actually had the opportunity to assist a little bit in this in the ER once. The patient was moving his feet around and they're using the groin site and they needed him to stay still. So I bent down underneath the sterile drape and held his legs still.
Yep. Good job. I love it. All right, Jenny, you are next.
All right, let me see if I can share. I don't know what screen's gonna pop up. Oh, there we go, screen 1 and screen 2. Share that. All right, are you guys able to see my screen?
Yes.
Possibly. Okay, perfect. All right, so I'm doing tools of the trays, finger splints. Before I kind of talk about finger splints, I just want to give you guys a visual of the joints that we kind of commonly use the splints for. So we have the distal, the proximal, and the metacarpophalangeal, which is our knuckles. And on the right, we have different types of finger splints, the padded type, as well as this kind of minimalistic, the oval 8 finger splint. And my son had broken a joint, and so I have a little bit of experience with these guys. So the minimalist one is really nice because you can pop it off really easy and wash your hand real quick and then pop it back on. So finger splints. It is an immobilization device that provides support to the finger. Indications for this is a distal phalanx fracture or tendon injuries, such as the mallet finger and the jersey finger that we have on the side, or dislocation of the distal interphalangeal joint. Contraindications for a finger splint would be like an open fracture, but we can use this if we're waiting to get into surgery. We need something to stabilize it. And then we want to watch out for the complications such as circulatory compromise if it's too tight, or stiffness if it's been in a splint too long. For the procedure, so I couldn't find exactly if it was a nursing or physician-led. I'm assuming more physician-led because an x-ray, or they do suggest that the x-ray and the reductions are done before you splint. So you're going to want to remove their jewelry, especially rings, due to swelling. And then you're going to want to measure the finger for the appropriate size splint because there's different sizes. And then you're going to apply the splint with the finger in the proper position and then tape or brace around the joint. So some of them come with like a, you can do like with the minimalistic one, you can use like a Band-Aid to brace it, or you can use tape, but they also have like a Velcro one that comes with some of them. For positioning, we have either a full extension for the distal phalanx fracture or the mallet finger, a 30-degree flexion for the jersey finger, and a 50-degree flexion for the MCP dislocation. For finger splints for the patient education, we want to let them know that fractures usually heal within 3 to 4 weeks. So they're going to look forward to wearing that for a couple of weeks. And then they want to keep their skin and the splint clean and dry. If the doctor does say that they can take off the splint and wash their hands or take it off while they shower, just make sure that you're keeping that finger in the right position. You're not going to be extending something that's supposed to be flexed or flexing something that's supposed to be extended. And then just look out for signs and symptoms of ischemia. And then talk to your physician if pain can't be controlled with oral medications at home. And then if you're there in the ER, obviously you're gonna let them know that they should follow up with their PCP within a week. For tips and tricks, they said for distal fracture, you're gonna wanna make sure to use a U-shaped or something that provides protection to the tip of the finger. Make sure all the edges are smooth, especially for those aluminum ones. And then only immobilize the joints that are indicated. So you're not gonna immobilize a whole finger if it's the distal joint. And those are my references. Thank you.
All right, Jenny, awesome job. Yeah, anyone could do this, including our techs downstairs.
Perfect. I was wondering that if there was if they're like a school nurse would be able to do it versus like in the ER, if there was a difference.
Yeah. Just as long as we have an order there. So awesome.
Awesome.
Okay, and Jocelyn, you're next.
Yes, let me.
Okay, can you guys see my screen?
We can.
Okay. All right, so I have buddy taping digits and indications for buddy taping, whether it's either fingers or toes. It's done to attach an injured digit to an adjacent uninjured digit, and this will help stabilize, align, and provide support to that affected finger or toe. It's done for a non-displaced stable fractures, reduced dislocations, and minor digit sprains. So some contraindications for the taping would be unstable or displaced phalangeal fractures, dislocations that remain unstable after reduction, any tendon injuries, or open fractures. Some complications with the taping would be skin breakdown due to lack of padding between the fingers and vascular compromise due to tight tape application. So for this procedure, you're going to insert a cotton gauze between the, or padding between the digits being taped, and that's done to prevent any skin breakdown. And you want to make sure that there's no wrinkles or folds in between the gauze that can put pressure. You're going to apply tape around both digits to bind the injured finger to the uninjured finger. You're going to use one strip of tape to bind the adjacent fingers between the joints. You do want to leave the knuckles untaped to allow them to flex and extend.
I'm so sorry, but I don't know if anyone's mentioned that we are still stuck on the intro slide.
Oh, you are? Mine's moving.
Jocelyn, try stop share and then share screen instead of your project.
Let me see.
Instead of the other window that's open.
Can you see it now?
Yes.
Yes.
Okay, let me go back then. There's really no pictures on it, so it's just what I've talked about. Let me see. I did want to show how to tape the fingers though. I don't know if you guys can see me.
We can.
Okay. So you just grab a piece of gauze, and then if I'm going to tape the middle finger to my pointer finger, you do want to avoid taping around the joints or the knuckles. So I don't know if you guys can see. And this is not the tape you want to use because it's this transparent tape that can rip really easily. So there's other tape at the ER that's more stretchy and like a fabric tape. So that would probably work best. And then you want to wrap around the fingers 1.5 to 2 loops. And you don't want to make it too tight just because it can compromise circulation. And then you would add a second piece to the bottom. And then of course, have them wiggle their fingers, check for any numbness or tingling, and cap refill.
All right, Jocelyn, thank you so much.
Oh, I have a couple more. So these are just some pictures of how it's supposed to look after it's taped, and then making sure you have the gauze in between fingers and toes. And aftercare for this would be arranging appropriate follow-up appointments, whether it's with the ortho or primary physician, depending on if it's a sprain or a fracture. You want to keep the tape and padding dry to avoid any skin breakdown, and change the dressing if it becomes wet. And they should be changing their tape at least once a day, but you want to make sure that they're continuously wearing it for 2 to 3 weeks. And then of course, educating the patient to seek any further care if pain's not controlled with over-the-counter medications at home. And that's it.
Yeah, good job, Jocelyn. It might be sending the patient home with some supplies like tape.
Yeah.
Supplies. Very good. All right. Anybody have any questions? All right, Nick.
All right, did I pop up there on the screen?
We can see you, yes.
Perfect. I look this big on the screen. So anyway, so I have the ring cutter or ring removal. Patient may develop swelling on the finger, the digit that has the ring on it if they're cat scratch, stung by a bee, any trauma or injury. It essentially becomes a tourniquet, so you have to get it off to reperfuse the digit. So obviously the first thing you want to do is least invasive. You want to try to use anything that can lubricate to help remove the ring, any like water-based lubricant or soap, anything that's handy. If that doesn't happen though, then you have to cut the ring off, and this is a ring cutter. It's used for soft wedding bands, or at least this particular blade, which is a chrome blade. It'll cut through gold, silver, or titanium pretty easy, or excuse me, platinum pretty easy. You guys can see this here. There's a little mandrel here on the side of it that's twists and actually is what does the cutting. Little pressure lever right here for your thumb. And then right here is the ring guard and ring protector. It's got a little notch in here, which will actually seat against the ring. And then this part here just provides protection against, cutting the flesh. So you'll seat that ring in there. It's good to take into the consideration the patient's ring, because it's always like some ring that their great-great-grandmother smuggled in, survived some crazy thing. So you don't want to be the jerk that destroys it. You want to cut preferably on the palmar aspect of the hand. So have them turn their hand upside down. And then it gets through it within like 20-30 seconds. It's pretty quick to cut through. And then I like to use 2 pairs of curved hemostats, and I grab both sides and just pull it apart and then take it off, because then they can take it back to the jeweler and have it rebanded, or the little clasp put on it. And again, the jelly will actually works great even if you have to cut it off, because it'll pick up all of the particulates that come off of the ring, the metal shaving. So then you can just wipe it right off and you don't have to worry about it embedding. They do make other blades for it, diamond blades, if it's like a steel ring, or if it is a titanium ring. I've cut off a steel ring before and didn't have the appropriate blade, and it took forever to get it off. But it won't work. Setbacks to it is it won't work for like a ceramic ring or a tungsten carbide ring. So I've never done this one myself. I actually looked at it on YouTube, but apparently they just use a pair of vice grips, and you take the ring and you put the vice grip on the ring and you tighten it to where you have good tightness. And then it's that last click will actually compress both the lateral and medial aspects of the ring, and it crushes it on itself, and then the ring just comes right off. Some of them have like a gold or silver inlay, so then you'll have to grab the ring cutter and go through and finish it up to get it off. But obviously you don't want to pull it off when it's partially fractured, because then you risk lacerating the tissue. That's all I got for you.
A note on the tungsten carbide rings, the vice grip probably isn't going to work. They actually make, and I know some ERs have them, they make a 3-pronged device that goes on it, and it actually hits the ring with a vibration, which will shatter the ring, because tungsten carbide is one of the hardest materials on the planet.
Yeah, that's what I thought too, but I actually was watching on YouTube quite a few videos on them. They just use it and it just compresses and it fractures the sides of them.
Really? Because I had a buddy who dropped a refrigerator on his hand, and what saved his hand was his tungsten carbide ring.
Yeah, I've heard that too. I've heard mechanics also say like it's the worst thing to have, because it's so hard to get off.
Nick, I have so many questions, including how do you just have a ring cutter laying around?
So I actually borrowed it from the urgent care where I work at. So we do it all the time, and I am always the one that's, I guess because I'm the bigger guy, I'm always the one that's, okay, go in and cut the ring off. I'm like, great. So I'm the bad guy. So
okay, that makes a little bit more sense. Was anybody else wondering that?
I know once I saw that that's what I was assigned to, I was like, this couldn't be any better. So
yeah, apparently. All right, good job. Rhiannon, you are next.
Okay, let me
see if this will work. Okay, can you see my screen?
Yes, we sure can.
Okay. So I have the tonopen tonometer. It's used to measure intraocular pressure. You'd use it with acute eye pain, acute eye injury, acute visual loss, a severe headache. If they have blunt force trauma to the eye, as long as the provider doesn't suspect a globe rupture. So you would not use it if a globe rupture is suspected, if they have a corneal infection or conjunctivitis, or if the patient has a latex allergy. So how to use, providers are the ones who will be using the device, but they will apply the anesthetic eye drops, apply fluorescein, calibrate the tonopen, and then the patient can just be sitting up with like their head rested comfortably to where they won't move. And then it's just like 4 quick little taps on the eye. And then it averages those readings to give you their intraocular pressure. And then the provider can interpret those results. So normal is 12 to 22. Anything above 26 is critically high, and then they need like an ophthalmology consult right away. Otherwise, I think below 26, above 22, they should be seen soon, but it doesn't necessarily need to be like right away. And I think that's all I have. Mine was pretty easy.
Awesome. Good job, Rhiannon. All right, Kirsten, you are next.
Okay, I'm going to share screen. Can you guys see that?
Yes.
Perfect. This is control panels over here. Okay, so mine was the level 1 rapid infuser. This is rapid infusion of resuscitation fluids at body temperature in trauma patients. It's a pretty cool little gadget. I was going to ask Karina if you ever used one of these or if there's a designated nurse for this.
Yeah, so if you're mass transfusion trained, then you definitely you get to use it a lot. I've had the privilege of using it a lot.
Okay, cool. So this restores blood volume, red cell mass, platelets, and coagulation factors. It can even correct acid-base balance, electrolyte disorders, and hypothermia. Oh, there we go. So I looked up the policy for CADLEC, and it tells you exactly when you would use this, specifically for hemorrhagic shock. Also, if hemoglobin is less than 9 and with bleeding uncontrolled with fluids, or if there's blood loss greater than 1,500 milliliters, and if a patient has received like 6 units of packed red blood cells in the last 2 hours and their systolic BP is still less than 90, any significant bleeding like a gunshot wound or to the abdomen or chest, ruptured AAA, profound GI bleed, and any other conditions with shock. This is the little cooler that the surgical RN, which I thought was interesting, goes and gets from the lab. It's a kit for the mass transfusion protocol. So the physician will activate the transfusion protocol and he'll place the order, he or she will place the order, and the blood bank will immediately prepare 6 units of packed red blood cells, fresh frozen plasma, 1 unit of platelets, and a unit of cryo, which is basically fibrinogen that helps clotting. I watched like 5 YouTube videos on how to assemble this thing and how to work it. So I feel like I could probably do it at this point. It's pretty nifty. Like you follow the steps 1, 2, 3, and 4. It's operated by 1 RN, and it has these 2 pressure chambers at the top where you would put your fluid bags. You don't run these simultaneously. It's just kind of one after the other so that the line doesn't get dry. It has a manual switch at the top. Can you guys see my mouse, or is that just me?
Yeah, we can see your cursor.
Oh, okay, cool. So up here, there's these little switches that will immediately pressurize the bags, and it'll run. It said on the instructions that the max flow is 950 milliliters per minute. I kept hearing it'll do a whole entire bag in like 2 to 3 minutes. It's really fast. There's a heating chamber down here. So when you get the tubing, you just follow these steps, and this chamber will heat the fluids. And then it has the air detector, which will clamp and stop the flow if there's any air in the line. And then it has on the right here, this set. This is what you would basically assemble with the 2 bags and hook everything into place. They kept stressing the importance of burping the fluid bags when you put them in, because that pressure is really it's gonna go quickly. So you also wanna have like an 18 gauge catheter so the fluids can run fast and not get, like the blood won't get hemolyzed. Also, you wanna make sure the patient the body temperature is 95 degrees at least. It's definitely not for small children under 20 kilograms. And then I already mentioned the surgical floor RN is the runner. She goes and gets the patient sticker, the pink card, gets the blood band and the cooler, and she documents all the product use. I got to watch one of these transfusions happen. I didn't realize it until I was learning this, what was really going on, but now I can see kind of all the steps that went into this. I saw the surgical RN and I thought that was kind of weird, but she was documenting everything, and I went to like kind of clean up the bags that were thrown all over the floor. They're like, no, don't throw those away. Don't throw those away, because she's documenting everything that's going into the patient. So that is it.
Yeah, Kirsten, you have to do that after the fact, and it really stinks because obviously you have to have your buddy there to sign off on everything that you had put in. And
Yeah.
I think, well, I haven't been in the ER too much in the last few years, but we did do 78 units one time.
What?
Really
Oh my God.
stunk to have
No way.
Yeah, it really stunk.
Did the patient survive?
Yeah, actually.
Wow.
Interesting case of like bleeding esophageal ascites. So yeah.
Wow. It's a pretty cool machine. It's really neat.
Yeah, awesome. Good job. And just
Thank you.
like you said, make sure that you're using a big old catheters, because you can at least 18 gauge for that rapid flow. Awesome. Okay, Kaylee, you are next. Oh.
I thought that said nose picking for a second.
Sorry, I'm trying to get my screen all in the right spot. So, okay, so can you hear me?
Yes.
Awesome. And you can see the PowerPoint?
Yes.
Okay, so mine is on anterior and posterior nose packing. So we'd use nose packing for nosebleeds, so epistaxis, and causes, there's lots of different things that can cause nosebleeds, using nasal sprays, inflammation, traumatic, or idiopathic. So there's least invasive options, which some of these have been talked about, like the nose clip, which Justine had talked about. There's also the use of silver nitrate sticks. So sometimes they'll use those to stick up there to try and stop the nosebleed. And then there's the Neseptin cream, which is more of like an antibiotic cream that they put in to prevent infections. So preparation steps for doing this. So you want to try least invasive first. You want to make sure you have consent, gather the equipment, and making sure you have personal protective equipment is super important, because you're sticking something up someone's nose, they could sneeze all over you and potentially get blood and mucus. So you want to make sure to have your goggles, your mask, your face shield, have a gown, a lot of chucks maybe. You want to make sure you have IV access and have pain meds on board, and reassure the patient. So the first one that I'm going to talk about is just gauze packing. And so this picture here shows where they go in the nose and then out the mouth, and it pulls the gauze back through to put it in the backside. And then to actually pack the gauze, this here, they use it by shoving the forceps in, and they kind of go back and forth and just keep shoving to fill this up. Nowadays, as far as what I read, like this isn't as preferred as using like the tampon placements. So these are sinus packs. This is like pretty cheap, a cheap, quick, easy version of a packing. And then the Rhino Rocket is kind of the gold standard. This one, you can soak it in the sterile water. And when you soak it in the sterile water, it becomes like gel. So it's self-sealing, self-lubricating, and it gets slid up into the nose, and then it gets inflated also. So that way it expands inside the nose to compress anywhere where there might be any bleeds. This gets taped to the outside of the face, and then it usually stays in the patient's nose for 2 to 3 days, depending on how long, and the patient can go home with it, and then they can come back and get it removed. So then there's also the option of using a catheter. And I thought this was interesting because I was like, is it really like a Foley catheter? And in some of the videos I was watching, it really was like just a Foley catheter. But I mean, you use what you got to use, right? So you shove it in through the nose, and then you grab it from the back to make sure you can see the balloon, inflate the balloon, and then you pull it back through. So that way you get a good posterior seal. And they actually make nose specific catheters that have 2 bulb systems. So that way you can do an anterior and posterior balloon inflation at the same time. It has, I think it has 3 lumens. This one looks like it has 2. But anyways, so that way it can be held there. But they're finding that the combination one, like the Rhino Rocket, where it's the gauze and the lubricating sealant and the balloon all together, is the most effective. So the doctor is the one who inserts these nasal packing devices, and the nurse just helps by helping setting up and gathering supplies and prepping the patient. And that's all.
Awesome job, Kayla. And remember, while you're doing this, A's, B's, and C's, so the airway can be severely compromised since that blood goes straight down to the back of the throat there.
Yep, and you always want to have the patient leaning forward. I think that was something that was brought up too, is like a lot of times people want to tip their head back, and that is like old practice, I guess. And so you want to make sure to have them tip their head or leaning their head more forward. And if they do tip it back, you can suction a little bit, but you also don't want to like deep suction on a conscious patient and cause the situation to get worse.
Yeah, for sure. Awesome, good job. All right, Jaleesa.
Yes, let's see. Okay, can you see my screen?
Yes, we can.
Let's see, I guess I'll just put slideshow. Maybe. Or the easier option down here. Yeah, there we go. Okay, so I got the umbilical cord prolapse, nursing management, and I think I clicked it. All right. So what it is when the umbilical cord gets comes out before the baby, basically, so it's hanging out, and it's an emergency situation because it can get compressed when the baby is trying to come out. So the definition here. Oh, sorry, I think I'm going back and forth accidentally. There we go. So the main important thing is that you need to know if you see the cord coming out, you immediately have to ask for help because it's considered a super emergent situation. So how this can happen if you have like fetal malpresentation, meaning like if the baby is coming maybe like the feet first or sideways, there can be some space left for the umbilical cord to come out first. You always want the head to be coming out first because it kind of, you know, seals that place and doesn't leave room for the cord to come out. Or if there's polyhydramnios, which is too much fluid, it can cause the baby to basically kind of float up, and that'll leave some space for the umbilical cord to hang out down towards the vagina that we don't want. Or if there's artificial rupture of the membranes, and if the baby's not like situated down low enough, then the cord can come out as soon as the fluid is ruptured. So for assessment is if you visually see the cord, you know you have the cord prolapse, and also on the monitor strip, if you see at the bottom, there's variable deceleration, and that means there's compression on the cord. And compression on the cord is a bad thing because then we're restricting like the nutrients and oxygen for the baby to have, and it can cause bradycardia and just bad things to happen. So what you do is you're going to immediately call for help. You're not going to leave the patient for any reason. You're not going to leave the room to go get help. You know, call out for help if you need to, or use the buttons in the room to get help immediately. You have someone notify the OR because this is going to be like something that gets taken care of fast and immediately. And then you glove your hands, and you're going to push up on the presenting part of the baby and try not to touch the umbilical cord or like maneuver the cord at all. So you push up on the baby, and once you have your hand inside, you cannot remove it at all, because if you do remove it, it can cause the baby to come down and compress the cord even more. And that would completely cut off like oxygen supply or to the baby. So you're gonna keep your hand inside mom to help alleviate that pressure until the baby is delivered in the OR. So that means as they're taking, you know, the patient into the OR, you're gonna be riding on the gurney with the patient. And then if you see that the cord is coming out, it can dry up pretty quickly. So you want to cover it with some gauze that is soaked in like some sterile saline water. And let's see, other, sorry, going back and forth. Other things you can do to help like alleviate the pressure from the compression of the cord is you're going to place the patient in Trendelenburg, like severe Trendelenburg, not just a little bit. Or you can do the knee to chest. If the patient's having, you know, contractions, you're gonna apply tocolytics. And if there's not already an IV started, you need to get that in stat and apply oxygen to the patient. And then my next slide, the first picture there that you see the hand, that's where you're kind of pushing the baby up and off of the cord. So it's not compressing it. And then the knee to chest position, that's just gonna like use gravity for the baby to get off the cord. And so those are some of the positions that will help out with that. And that's it. Thank you.
Awesome, Jaleesa, good job. Yep, you just put that hand up there, and I had myself a very traumatic experience with this because we had someone come in with that, and during a fire drill, and so the elevators were turned off, and we were like, you need to get these elevators because we do not want to do a C-section downstairs. But
that sounds terrifying.
Yeah, it was interesting. All right, lady, are you okay to have internet service?
Yeah, I think so. Can you hear me?
Yep.
Okay, I just had to change to a different spot of the house, so hopefully that does it for me. So give me just a sec. I'm going to share my screen. Let's see. Can you guys see that?
Yes.
Yes, okay. All right, so let me just get settled here. Okay, so I'm doing mine on vagal maneuvers. So vagal maneuvers are usually a first line or first choice treatment for SVTs or supraventricular tachycardia. And this is why, the reason why is because they're low risk and they're low cost. So how do they work? Simply put, they slow down electrical impulses. And they do this by affecting the vagus nerve. And essentially it sends signals to the AV node and it disrupts the flow of electrical energy flowing through the heart. And so hence it results in a slower heart rate. So there are different types of vagal maneuvers. One of them is a Valsalva maneuver, which I will go into more detail in the following slides. So I'll leave that for later. But it also includes the cough, which is where you cough with enough force to generate pressure in your chest and stimulate the vagus nerve. It usually doesn't work too well with children because they just don't have like enough strength to cough hard enough to initiate a response from the vagus nerve. We can also do a gag. And this one we know you just use your finger, or if we're in a clinical setting, you would use a tongue depressor. Next, we have hold your knees against your chest. So you just do this for about a minute. And usually this may work best for like the smaller children and the infants. And then we also have cold water treatment. So this can look like different things. So can also be called the diving reflex. So you can use a plastic bag, fill it with ice and place it on the face for 15 seconds. Or you can immerse the face in icy cold water for several seconds. Or you can just have a really cold shower or a really cold bath. And then we have the carotid sinus massage. So this should only be done by a doctor. And this is where we have the patient lie down and stick out their chin. The doctor then places pressure on the carotid sinus. And you can find this on the neck, just below the neck. And that requires some monitoring during the procedures. That's why we need a doctor in there. So the Valsalva maneuver. So this is essentially a breathing technique, and it can be used to restore heart rhythm, diagnose an ANS disorder, or even treating a clogged ear, which is kind of interesting to me. I'm not sure how commonly it is used for this, but I did find that in my research. So to restore a heart rhythm, so the way this works is during the maneuver, the blood pressure shift in the heart rate shift as well can often cause the normal heart rhythm to restore, if that makes sense. So there are 4 phases of the maneuver, which we will go into in the following slides, but this shift in the blood pressure and heart rate that happens through these 4 phases usually helps us restore heart rhythm or normal heart rhythm. And for diagnosing an ANS disorder, so the way this works is the pattern of the heart rate and the blood pressure changes, just kind of like it fluctuates between the phases. And so this can help the doctor or the provider, whoever's monitoring during this procedure, identify any problems with the sympathetic and parasympathetic nerve functions. So for example, if you have a condition called the postural orthostatic tachycardia syndrome or POTS, you'll have significant increases in blood pressure in phase 2 and 4. And then to treat clogged ears, so this can help with like not crazy issues, something like maybe you have air that's blocked, that's blocking the eustachian tubes in the inner ear. So you can use this maneuver to try to pop your ears, if that makes sense. So how to perform the maneuver. So number 1, you want to pinch your nose. Number 2, close your mouth. So you want to kind of have that closed airway, if that makes sense. Then you try to exhale and you bear down as if you're having a bowel movement. And then you do this for about 10 to 15 seconds. And it can be done sitting or lying down. So you go ahead and do that. And then let's see. So about the 4 phases, so there's phase 1, and this is where we have a temporary spike in our blood pressure. So the way this works is when we're blowing air against our closed airways, when we're bearing down, this causes some increased pressure in our chest. And this can then lead to that spike in our blood pressure. And the reason why is because we have pressure increasing in the aorta. So it causes the blood out of your heart to be increased as well. And then phase 2. So this one's a steady drop in blood pressure. So, and this is caused by, the reason why this is caused is because there's limited amount of blood in our veins that are returning to the heart. So this is obviously going to affect our blood pressure. And then for our phase 3, oh, then something important to note here. So as mentioned earlier, when we're diagnosing issues with the ANS, so at the end, we should have our blood pressure return to normal if our ANS is healthy. If we don't have a healthy ANS, then we're going to see some issues there. And then for phase 3, so this is usually at the end of the maneuver. So this is when we're relaxing and our blood pressure starts to fall for a few moments. Phase 4, the blood will start to return back to the heart pretty rapidly. So after a few heartbeats, the blood flow should be back to normal and your blood pressure will rise because our blood vessels are still constricted. And ideally, the blood pressure will increase, causing the heart rate to come back to normal. So caution, so we do have to be careful with our patients who have heart disease, glaucoma, increased intracranial pressure, or who have a new surgical wound. The reason why is because this can increase pressure within the abdominal cavity, it raises our blood pressure, and it's also associated with an increased risk for cardiac arrhythmias. So we want to advise our patients to, talk to their doctor before they're trying this technique, make sure that it's appropriate for them. Also, trying the Valsalva maneuver to clear our ears or to pop our ears should be done carefully, because if you excel too hard, you could rupture an eardrum. And the nurse's role, well, I didn't find too much about this, but the big takeaway is education. Education is big on this. So we have to teach our patients, the simple things, how to perform the procedure, when should it be used and the risk associated. In a clinical setting, we want to monitor ECGs if they're on an ECG. We want to look at the rate, the rhythm, conduction. We're assessing vital signs, reporting any abnormal changes, and then just explain to the family and to the patient, why we're doing this, etc. And that is pretty much it. Are there any questions?
All right, lady, good job. Yeah, oftentimes the nurse is going to be the first one to take a look at that EKG or have the patient on the monitor and notice that SVT, and these are definitely things that we can do just right off the bat, is ask them to perform vagal maneuvers and all those maneuvers. Yeah, good job. All right, Lizette. And then after Lizette, we will take a break.
Can everyone see my screen?
Yes.
Okay. So I got foreign body in the nose. So who's at risk? Smaller children, usually toddlers and preschoolers, so between ages 2 and 5. And then intellectually impaired individuals, especially if they have a history of like previous foreign bodies in their nose. What objects? So usually small toys or objects. I always think of like the little Polly Pockets, food, paper, and then the more serious ones are button batteries, magnets, and super absorbent polymers. So what we'll see malodorous, purulent, or bloodstained nasal drainage, epistaxis, mouth breathing, facial swelling and/or facial pain. So if there's unilateral foul-smelling discharge from the nose, you should always suspect a foreign body and assess for that. And then if there's bilateral drainage, you should also look for it, because sometimes if they placed objects in both nostrils, you'll have bilateral drainage, or if the septum was perforated. But typically when there's bilateral, it's like more signs of upper respiratory infections and sinusitis. Diagnostics, depending on how impacted it is, visualization is usually the most common. So you can use an otoscope or headlights. If it's more in the posterior part of the nose, you can do nasal endoscopy, or use an X-ray for button batteries and magnets that aren't directly visualized. Treatments or procedures. There's positive pressure techniques if the object is in the anterior portion of the nose. So what you'll have the kids do is, or the person do, is occlude the unaffected nostril and like blow their nose. You can also have the parents assist with this, and same thing, you'll have them occlude one of the unaffected nostril and then blow in through their mouth. Or you can also use an ambu bag. For instruments that you can use forceps, a probe, suction, a balloon catheter, which is right here, or a magnetic device, but always use topical anesthesia. I think this is more like provider, maybe like positive pressure techniques would be more nurse. I couldn't find information on like who could do which, but some important things to remember is that button batteries require immediate removal due to risk of tissue necrosis and septal perforation. And then you don't want to instill any nasal drops, local anesthetics, and vasodilators, because if they have a button battery in there, it can increase the risk of displacement, aspiration of the toxins, or local necrosis. And then in certain instances, you'll need like an urgent referral of an ENT. And those are if there's nasal stenosis, perforation of the septum. There was multiple unsuccessful attempts at removal of the object before they came into the ED. You're unable to remove it after the first attempt at the ED. There's a button, they have a button battery. There's magnets that are paired at the nasal septum, so one opposite of each other in each nostril. There's penetrating or hooked foreign bodies. And then if the foreign body is in the posterior part of the nose and not easily visualized. And then these are my references. That's it.
Awesome, good job. We found that, well, we always call it the mother's kiss, but the parent's kiss, I guess, seems the most appropriate to be super effective. They just plug the unaffected nostril and blow into the mouth as hard as they can, or give a good puff, and that usually tends to knock that out. Good job, Lizette. All right, Kelsey, you're going to be next, but let's take a break. It is 10:38. Let's come back at 10:50. Does that seem like okay? And once again,
okay, hi guys. Let me go to full screen here. Okay, so I have foreign body in the ear, which is just an object in the ear that doesn't belong there. And today I'm going to talk about two types. So just foreign bodies in the pinea, so this external part, and then foreign bodies of the external auditory canal, which is right in here. So foreign bodies of the pinea, so this external part that we see, so this usually arises from embedded piercings located on the earlobe or just the cartilage part. And the embedded earrings are most common in girls under the age of 10. and young adolescents who are just less likely to have, adequate hygiene behaviors and, kind of like just to touch their ears a lot. So some clinical manifestations. So they'll just have ear pain, swelling, redness, some yucky discharge. And the diagnosis is based upon clinical features. So, if they've recently undergone an ear piercing, or they may be able to palpate the earring on the earlobe. Or if you can't physically, see or palpate, then you can perform an x-ray. And complications to, embedded foreign objects, obviously, that can lead to infection, infection of the skin around the tissue, and also disfigurement of the ear, which is this picture right here. It kind of looks like a cauliflower ear. And then foreign bodies of the external auditory canal. So the most common location of a foreign body is this canal, and it's particularly common in pediatric patients. And I read an article that says the pediatrics occurs mostly in the right ear due to the predominant right-handedness of kids. And the most removed foreign bodies include beads, paper or tissue paper, and popcorn kernels. So everybody loves popcorn, right? And so this diagnostics is based on a physical exam and looking into the ear canal, obviously using the otoscope. So in adults, you want to retract the pinea gently up and backwards. And then in kids, you want to pull the pinea down and kind of back to open up that ear canal. These are just some pictures. So up here is I just wanted to show you how you can have an assistance or maybe the parent hold a child while they're doing an ear exam. And then over here, this gentleman, he's sitting upright, has that kidney basin, and this nurse looks like they're performing an irrigation. And we'll go over the process of that. And then the picture down below, this papoose restraint, I think was mentioned in Cindy's presentation as well. So just kind of helps, our little patients not move around. And then you have someone here kind of holding the head so they don't move around on you. So when is an emergent removal of a foreign body? So we want to immediately remove button batteries because an electric current can form in the body, and it can cause like the necrosis and tissue burns. If we have any potentially penetrating foreign bodies in the ear, such as like a pencil, bobby pin, or cotton tip applicators, an emergent removal also includes a foreign body with evidence of injury to the canal or the tympanic membrane or middle ear. And then also an emergent removal if we have insects in our ears, because insects can cause considerably lots of discomfort and can potentially damage the middle ear or the tympanic membrane. And insects should be killed with mineral oil, ethanol, or lidocaine prior to attempting to remove them from the ear canal, because otherwise they're just going to be moving around in there. So there's 4 different methods of removing foreign bodies in the ear. So one is irrigation, removal under direct supervision, suction, or super glue. So irrigation, this is used to remove small objects or insects, and it's contraindicated if you have the tymphostomy tubes, perforated tympanic membrane, or any material that's stuck in the ear that's going to swell up and cause an obstruction, or those button batteries. We don't want to get those wet. So the equipment used, you want to grab a 20 to 50 ml syringe, irrigation solution. It should be lukewarm or body temperature water, sterile water or normal saline, and then a 14 to 18 gauge. And you can just use the plastic IV catheters. Obviously, just take the needle out. And mineral oil or lidocaine is used to kill live insects. And then grab a kidney basin to collect the irrigation solution, a towel to drape over the patient, and then also the elephant ear washer is a different device, and I have a picture of that on the next slide here. Oh, must be the next slide after this. So the irrigation technique, so you want to use the otoscopy to ensure that you don't have a ruptured tympanic membrane and you don't have any of those tubes present. And then you're going to place the patient either supine position or with the affected ear side up, kind of restrain as needed. Or if you have, an older patient, like an adult that's cooperative, you can either lie them down with their head up at 30 to 90 degrees, or they can remain seated in a chair, kind of with their head tilted for the drainage. And if you're removing an insect, like I said, you want to instill the mineral oil or lidocaine to kill that insect prior to irrigation. You're going to place a towel or a chuck on their shoulder, and then a basin under, kind of tucked under the ear to catch the irrigation solution as it kind of flows out of the ear. And then you're going to place the catheter or the plastic tubing approximately 1 to 1.5 centimeters into the EAC. And then you're going to irrigate, and you want to have the catheter tip kind of among the posterior and superior margin of that ear canal and kind of briskly flush the syringe. And then you're going to just keep repeating the flushing until you can expel the foreign body. And in some instances, when you irrigate, the object moves toward, the auditory meatus, but you can still use like an extraction instrument if it's close, just to get it out. And you always want to conduct a post-procedural ear examination to confirm that you've completely removed the foreign body. So here is a picture. So you have your syringe with your saline or irrigation solution, and here's your catheter tip. So this is a good picture. You want to make sure your cannula is up here at the top of the canal. That way it'll flush, whatever foreign body is in there out and collect it into this little kidney basin. And this is a YouTube link, you guys, I can share with you. It's kind of just shows the process of doing an irrigation. And over here is the elephant ear washer. So you just fill this with, your normal saline irrigation solution. And then there's a little catheter tip already on here. And you just insert this little catheter in there and just use the squirt bottle to irrigate the ear. And I've seen this in the emergency department, so it's pretty cool. So removal using instrumentation under direct visualization. So there are lots of special equipment that can be used to remove foreign bodies in the ear. And the instrument kind of depends on what kind of foreign body you have in there. So these are what's called alligator forceps. We have your otoscope, and we have your right angle ball or day hook. So you can see this 90-degree angle, and this one just has a little ball on the end. Also, you want to grab a headlight can be used. This metal curette comes in different sizes, super glue, and some swab sticks. Also, we have the Grindwald bayonet nasal dressing or Luque forceps. They're kind of shaped a little funky. Gloves, your catheter, and syringe if you're not using the elephant squirt bottle, and then mineral oil, lidocaine, and obviously your kidney basin to collect. So here, using instrumentation, this procedure, so you're gonna, place the patient either supine with the affected ear up, restrain if needed, control pain, safety, sedate if necessary. And here is a picture of them using those alligator forceps to remove a little bug in there. And this is a live picture of a tick in the ear canal. So you guys are probably all itching your ears right now. And this one, so soft objects like foam or rubber or paper, those with protruding surfaces or irregular edges and insects can be removed with these alligator forceps or the bayonet forceps. And for suction removal, they use this tool, and I'm going to butcher the name, the Schultz Connect foreign body extractor. And so this is used for spherical objects. It's best used to remove them with suction. And so this is what one looks like here. And this is kind of zoomed in of what the tip of it looks like. And it looks like this picture is sucking out a little marble or bead. And then lastly, they can use super glue, which I thought this was interesting. So it's been used to remove wedged or smooth round foreign bodies. So you're gonna place a little bit of super glue on your wooden end of your Q-tip, and with direct insertion, you're gonna stick it onto the foreign body, and then that little Q-tip with the glue on it, as you put it to the foreign body, you want to wait at least 60 seconds to ensure that the glue has dried, and then you can extract the object using just a little gentle motion. And here is just the picture. So objects that are round or breakable can be removed with this right angle hook. Also, these were included in angle wire loop or angled the circumcurrent. So you're gonna wanna slowly advance this beyond the object, and then you use that kind of right degree angle to kind of carefully withdraw it out of the ear canal. And these are my resources. So yeah, it was kind of fun. Do you guys have any questions?
I love that you guys have already gotten some experience with some of these tools. You guys have had some really fun rotations, haven't you?
Yes, it's been fun.
All right, good job. Jasmine, you are next.
Okay, I'm just gonna try to share my screen. Hold on. Okay, so it's saying desktop 1, system preferences. I mean, which one would I click? Karina.
Has anybody else gotten that and know how to assist?
What's the error say?
It's saying, so I'm clicking share screen and then it says desktop 1. But it's not, and it's saying, it's not letting me.
Is there a small blue icon in the bottom corner where it says desktop 1?
Yeah, that's what it's saying. Desktop 1, and then I click it, and then nothing happens. Or, right, you guys don't see anything?
Jasmine, go ahead and message me that PowerPoint in Canvas and we can do it that way.
Okay.
And in the meantime, we'll have Donald present.
Okie dokie.
Alrighty, let me see, share screen. Can everyone see my screen?
Yes.
Perfect, perfect. Okay, so I got foreign body in the vagina and then prepping for the pelvic exam. So what is it and how does it happen? It is when an object becomes lodged in the vaginal canal that can be removed by the patient themselves and needs medical intervention. This may include feminine products, drugs, IUDs, sex toys, toys, or other foreign objects. If it's a pediatric patient, it recommends that you roll out any kind of sexual abuse. Or for an older adult, if you suspect it could be from sexual abuse, obviously go through those questions. The vaginal exam prep. So first you want to obtain vital signs, assess for signs and symptoms of infection, kind of get a history of what led up to it. And then you want to make sure to get that the physician obtains consent from the patient to do a vaginal exam and asks if the patient prefers a female, if it's a male doctor, just to make the patient more comfortable. Once consent is obtained, the nurse will have the patient change into a gown and remove everything from the waist below, providing privacy. The RN will set up a tray with forceps, non-sterile lubricant, speculum, a good light source, gloves, and culture swabs. And there should always be it should always be the provider and one other medical professional, just to help the patient feel more comfortable, and probably for liability reasons. Patient will be before the exam begins, the patient will be put in the dorsal lithotomy position. And what happens if the foreign objects can't be seen? If foreign objects can't be seen by a pelvic exam, or it's contraindicated to do a pelvic exam, they can do an ultrasound, an MRI, an X-ray, or a CAT scan. The physician will determine that. If surgery is needed to remove the foreign object because it's too big, because the way it's lodged, too sharp, certain surgery is needed, consent will need to be obtained for that, and the patient prep for surgery. For any pediatric patients, the gold standard from the article I read was the transabdominal ultrasound. And some complications that can come about from that is ulceration, fistulas, inflammation, acute or chronic. Chronic if the object was lodged for a long period of time. Vaginal stenosis, especially if it was a corrosive device that was lodged in there, like a battery, and toxic shock syndrome. And my reference was Anderson J. and Paterick E. And that's from PubMed Stat Perils Publishing. And yeah, does anyone have any questions?
All right, awesome, Donald. They usually use something called ring forceps, which is forceps with kind of circles at the end of those to extract. So you might see ring forceps.
I actually saw it happen when I was doing a rotation in the ED at Lourdes. A patient came in, she had some tampons stuck up there. So yeah, I was trying to find the actual name for the actual forceps that they use, but I wasn't able to find it. So sorry about that.
Hey, no problem. Good job. There's I guess the bottom line that you guys just discovered is if there's an entrance, then there's a chance to get a foreign body in there. Okay, let's see, Jasmine, if I can.
I'm going to try really quick one more time.
Okay.
And if not, yeah, it's not working. Never mind. Go ahead.
Let me get into it.
Sorry.
Okay, no problem. Hopefully this makes you guys more tolerant
Yeah.
of your crazy instructors. There you are.
Okay. So I have a foreign object in the esophagus. Could you just click next, please, Karina?
Trying to. Yeah, there you go.
Sorry. Okay, so it usually occurs in pediatric children up to 5 years. It's common just because they're very curious, stick everything in their mouth. It could happen with adults as well. Signs and symptoms you may see: difficulty swallowing, neck pain, trying to cough, and then having pain with coughing, drooling, gagging, vomiting, and refusal of food. The nurse's role is to take vital signs, history from parent, current meds, allergies, assessment, provide O2 if needed, 2 large bore IVs, suction for drooling, check orders for medications, check the x-ray, reassurance for the parents and then of the patient teaching. So this is for like afterwards when everything's okay. Just educating of maybe baby proofing the house, picking up little things off the floor, proper way to cut and serve food. So for like different age groups, so there's certain ways like to cut grapes and all that stuff. Pre-op checklist. So the last time they had their meal or fluids, putting them on NPO just in case they're going to have to get surgery. Current meds, allergies, consent, and then patient teaching if they're going to have to like go through surgery. And then the diagnostics, X-ray, CT, EGD, laryngoscope. So this is right here. That's a safety pin. Looks very painful. Poor little guy.
Yikes.
Okay. Yeah. Medications that the nurse would be expected to give. Glucagon, it relaxes the esophageal smooth muscle and the lower esophageal sphincter. So it helps promote passage of impacted food or whatever is in there. The nitroglycerin and the calcium channel blockers, they're going to relax the smooth muscle in the throat. Coca-Cola, this one was interesting. It penetrates the bolus and disintegrates it by releasing the carbon dioxide. Also, if it seeps into the stomach, it will release gas. And so with burping, it can dislodge the bolus. And then if you're 21 years or older, I was reading in the article that champagne might work as well. And then next, tools. So there's the forceps they look like the little scissors there. Then the Roth nets, the coin grasper. Extraction is used. So if it's a battery or like definitely like a safety pin, so you want to get that out. If it's like food or something that can be digested, or then they'd probably push it down with the scope. But usually, like I said, if it's batteries, endoscopic removal is done. And then I found this in an article, which I thought was interesting. So Foley catheter, so fluoroscopically guided for the removal of coins. So it's used for pediatric patients with no signs of edema. It's not used widely due to the possibility of complications, and there's not a direct visualization of the esophagus. So you'd insert the Foley catheter all the way down the esophagus with the guided fluoroscopically guided. And you go all the way below the coin, and then you're gonna inflate the balloon and pull it back up. And I was reading, I believe it was ketamine that they give prior. But like I said, it's not widely used. But I just wanted to add it in there. And that's all I have.
All right, awesome. Did anybody have any questions? Okay, good job. Kashmir.
Okay. Okay, am I sharing my PowerPoint?
Oh, we can definitely see what you're seeing right now.
Okay, perfect. Okay, so I had Mac and Miller blades. Mac is short for Macintosh. They are laryngoscopes used for direct larynx visualization, primarily used to guide endotracheal intubation. So on the right side, you can see there's different sizes of the Mac and Miller blades. The Mac is this more curved blade, and the Miller is the straight blade. And then this kind of green thing is the handle. And so so you just attach, there's like a little notch to attach onto the handle. And then kind of the different parts of the blade. The base, like I said, is where you attach it. And then the tongue, kind of, that's the part that slides over the tongue. And then the tip is kind of what will press down to view the trachea, the epiglottis. And then there's like a little light bulb here too, so that to light the way so you can see. Indications are mostly, you'll see it in the OR for general anesthesia, laryngeal procedures, resuscitation, like respiratory or cardiac arrest, or if we have someone with decreased mental status that can't regulate their respirations, then they might be intubated as well. Contraindications are laryngeal fracture or dislocation. So if we can't get it in there straight, and then cervical spinal fusion, it might be difficult to position the neck in order to get it in there. Who can use them? So pre-hospital, you'll see EMS do field intubations using the Mac and Miller blades. Respiratory therapy can do intubations, obviously anesthesiologists or CRNAs in the OR, physicians, and then Department of Health for Washington actually states that specially trained RNs can also use these tools. Okay, so it's kind of tricky to show what the procedure is for using these blades. So I'll just kind of talk through it. So the first thing is if we're able to hyperoxygenate the patient via nasal cannula at 15 liters per minute, that's super important. We want to have obviously all of our monitoring devices on them, continuous pulse ox and cardiac monitoring. We want IV access. We want emergency surgical airway kit at the bedside. Then we'll place the patient in what's called the sniffing position, which is kind of, it's easiest if like the occiput is on like a pillow or something like that, to kind of arch their neck back to get a good view. And then the person performing it will be at the head of the bed. And so it's kind of, as you can see in this picture, it looks kind of upside down view.
And then the easiest way to get the patient's mouth open is not spreading the fingers apart from each other to open the mouth, but actually using more of this scissor technique, if you can see on the bottom in this gray picture. So kind of crossing the pointer finger over the thumb, and that way you have more strength, and it's easier to open the patient's mouth that way. Okay, so then you'll take the laryngoscope, and if you're using the Macintosh blade, then you'll kind of match the curve of the tongue and insert it into the right side of the patient's mouth, and then kind of try to advance it towards the midline by rotating it rotating the tip of the blade towards the back of the tongue. And then once you get down there, there's this landmark called the vallecula, and that's at the base of the tongue, right above the epiglottis. I have it circled in yellow here. And so with the Macintosh blade, that's where you'll engage the tip of the blade. It just kind of slides right in there. And then it automatically just opens up the epiglottis for you. If you're using at the top, this middle picture, if you're using the Miller blade, it's got that straight tip. And so you can just maneuver it to manually open the epiglottis. And then after that, you can just slide your ET tube through the blade to intubate. And I found this picture I thought was kind of cool to be able to see the view through the blade, and you can see the ET tube going through the trachea there too. And then some complications of this procedure is obviously trauma to the oropharynx, larynx, or trachea, chipped teeth, lip laceration, vocal cord damage, or sore throat. And that's all I got.
Excellent. Yeah, does anyone have any questions? All right. So one of the ways that people remember the Mac and the Miller is Mac has a C in it, so it's kind of C curved, and the Miller looks like it, or it has L's in it, so it looks like an L. So if a provider asks you real quick for Mac or Miller, you will know, and then they'll specify the size, and those are in all of our code cards there on the floors. All right, Charlotte. Charlie.
You said Charlie, right?
Charlie or Charlotte?
Charlotte.
Oh, sorry.
Okay, that's okay. Okay, I'm gonna try and share my screen. Okay. Can you guys see it?
Yes.
Okay, so I have Glide Scope, and it's by me, obviously. So what is a Glide Scope? So Glide Scope is like the company, but they produce video laryngoscopes, kind of like what Kashmir just shared. So they're the first company to produce video laryngoscope, and they did that in 1999. They have single-use bronchoscopes, children to adult-sized laryngoscopes, and then they have these little portable systems for intubating, like out in the field. And so what does it do? So it just visualizes the airway for emergency intubations, well, and also routine. But so I guess like the unique thing about the Glide Scope is it's hyper angulated, whatever that word is. So allows to follow the curvature of the tongue and just like the general anatomy of our mouths. And then it just uses less force to expose the larynx for visualization. And then, so I just put like a couple of their different like systems, I guess, that they have. So the GlideScope core, which is like this big thing here, and has like a side-by-side view of the larynx and vocal cords. Kind of, I think it's supposed to be on the left like all the time, and then on the, like, once you get there, and then you can have your view on the right would be of like the trachea, and then you can go down into the bronchioles if they're doing a bronchoscopy. And then again, they just use these when they're intubating someone or for bronchoscopies also. And they have like this whole setup, I guess. And so here's the different laryngoscopes that GlideScope has. They have like the traditional Miller, which is here on the left. And then they have the Mac, which is here on the right. But you can tell this one here in the middle is their hyperangulated like specialty style thing that they have. You guys can see this, right? It's
Yes, we can.
okay. So you guys can tell like how much more angulated it is than the Miller or the Mac here on the right. And they had several like statistics on how much better this hyperangulated one works versus just a Miller or a Mac or Miller style laryngoscope, but they do carry them also. And then so here's this cool little thing. It's called a GlideScope Go, and it's like a little portable one. I think they said it's about 3 inches, the screen here, so it's like really tiny, but can just be used if you're in like a really tight cramped quarters or out in the field, whatever. And again, that top part is like the video part, and it doesn't have the dual screen, but it's still kind of cool for on the go needs, I guess. And it is reusable. So like here where this gray thing is, it just kind of pops off, and you would just put a new one on between patients. So it reduces like spreading infection and whatnot. And they come in a bunch of different sizes, which is awesome for different like sized patients. So the nurse's role, so I looked it up, and it sounds like in Washington, an RN can perform an endotracheal intubation. And all it said was under the direction of an authorized healthcare provider. So I don't know if that means they like have to be in the room, or I don't know, or if it's like a standing order or whatever, but and then when using the GlideScope in the ER setting, the nurse would, I guess try and get a consent, but I doubt that happens very often, or checking for allergies to like the anesthetic or whatever medications they're going to be using if they can. And then just getting supplies for the CRNA or the anesthesiologist, and then ensuring suctioning equipment is nearby at the bedside, and that the patient is attached to monitoring equipment like their vital signs, their oxygen, and an ECG, and that's it.
Awesome, good job. Can anybody think right offhand who, in what situation a nurse might be intubating somebody?
That's what I was trying to find, but it's like so vague, I guess. I don't know.
Yeah, definitely our flight nurses.
Yeah.
You just have to get checked off. You have to be seen, like checked off doing it prior to. So yeah.
Oh, in Washington State. Is that what it? Oh, okay.
All right, good job. All right, Jennifer.
Okay. Can you see my screen?
Yes.
Okay, yay. Okay, so I had, let's see if I can get that started. And I'm gonna try to see if I can pronounce this right, but it's toluidine blue, used during a rape kit. So first of all, we think about rape, we're talking about, and this is according to the FBI, penetration, no matter how slight, of the vagina or anus with any body part or object, or oral penetration by a sex organ of another person without the consent of the victim. So what is it? It's a thiazine metachromatic dye with high affinity for acidic tissue components, so thereby staining tissues rich in DNA and RNA. So it's a tool used as part of a rape kit to document genital and perineal injuries following sexual assault. So part of a rape kit, they use to gather forensic evidence. So like fibers on clothes, hair, body fluid, maybe cervical tissue samples. And so this is another tool that they can also use. And so yeah, it can be used as physical evidence to corroborate a claim of rape, because sometimes we don't have a lot of evidence, and so this is one thing that they can use. So genital lacerations are considered evidence that a rape has occurred, and so the toluidine blue increases the detection of these perineal lacerations to support the documentation of evidence. So wherever the epithelium is damaged and underlying cells are exposed, the nuclei will stain blue. So that if there's injury sustained during genital penetration, it'll show the distinctive distribution. Okay, so some of the issues that in some of the studies that I read were improper handling of examination speculum, or like when they do the exam and insert the finger, because obviously sometimes that can cause damage to the area. So they found that it's best to do the toluidine blue test before they do any speculum or digital examination to collect evidence. And then another study I read said the detection of vaginal lacerations in reported rape victims increased from 1 to 24 to 14 and 24 with the use of the toluidine blue. It's safe and easy to use. It's available and inexpensive. It doesn't interfere with other medical legal evidence, and so it's recommended in the examination of rape cases. And then, so it's the healthcare provider, so the nurse's role to collect all the possible evidence, and then, then it is over to the courts to determine what evidence is admissible to ensure a rightful conviction. And those are my references. And that's all I have.
All right, Jennifer, good job. So another tool in our toolkit, and I will be talking about rape at a later date. All right, Charlie, you are up next.
Okay.
And Jennifer, try to stop sharing. Yeah.
Got it.
Can everybody see this?
Yeah.
Right. So I have the bear hugger, and just a little introduction over what we're going to go over. So the first part of it is the continuous temperature monitor, and it just really goes right on someone's forehead, attaches to the little device here, and it could be used for adults or pediatric. It's single use for the sensor, and basically its function is to do a core temperature, and it's continuous, so it stays with the patient, and it could give up to 2 hours of graph data. Could also be used for Celsius or Fahrenheit. And that's pretty much it for that portion of it. Then we go to the blanket and the unit portion. And this is to prevent and treat hypothermia. The warming blanket's disposable and it's used directly on the patient's skin. So to prep for your patient, it's kind of in a pouch. So you undo the pouch and you place it up towards the head of the bed and kind of just roll out the blanket. And then on the sides, they fold out, and there's a fold under the sides that tuck into the stretch, like under the table or the stretcher, to secure it. And there's also this piece that you'll find in there that's a clear head drape, and you just set that aside. It may or may not be used later. And then there's a round sticker that should be at the top of the bed. So that's how you know that it's at the head of the bed where it should be. And the back side of it has its adhesive stickers that you could take off the paper portion and stick on, so it's secured. And so you also have these sides, and the sides have some perforation. So depending on the position of your patient, you would open up the perforation. So for prone positions, you open the perforation, and then you actually would tear out a circular portion at the head of the bed for the face later as well. And there is this plastic piece that you would only use in the case of someone being mechanically ventilated. So it's really important that unless they're vented, you would not use this. But it covers their face and neck, and then there's also more adhesive to secure it around their neck. So if it's in a supine position, then you actually put, as you can see here, there's a draw sheet, and you place it over it kind of like a draw sheet, essentially, but it's going to go down on the inside of the perforations once you opened it on each side. And then if you put your patient on the table, it actually goes over their arm and under the blanket, and then it tucks in also under the table to secure their arms in on both sides. If it's a person that's going to have an arm extension board, then you don't use a draw sheet. These preparations could also be used if you have a belt to secure the patient as well. And so the arms are just extended out, and it goes under, as I said, the blanket if the arms are extended versus to the side. If they're lateral, let's just say we're going to roll them over this way to the right. One side would go under the blanket, the other side goes over. So you would only have to perforate one of the sides. And if they're prone, you would have them put their head in the head where it's perforated out and extend the arms through the sides of the blanket as well. And then you would be able to start warming your patient. So as you can see in the picture, there's a hose attached to one side, but this port is actually on either side, the head and the tail of the blanket. So you decide which one you're going to use the hose with. The other one, there's one port card in place in one of them, and you just move that port card to whatever one you're not using. And then the other one you attach the hose, and it's just a twisting like motion to secure it. And then you're just going to make sure your unit is plugged in, it's turned on. You select your temperature and your fan speed, and then you're just going to continually assess your patient while in use every 15 minutes for that core temperature and skin assessment. And this is the ideal temperature for a blanket. And then at the end, you're just going to turn it off or put it in. That could be done by turning it off with the power button or standby. It just really depends on which model. And then this is just a really interesting tidbit. So Dr. Augustine is a person that invented it in 1989. It is FDA approved. However, there's this huge and has been class action lawsuit over this. And he has allegedly said that he also agrees that this blanket can spread bacteria-associated hospital-acquired infections per the New York Times. So he's actually on a campaign to try to pull or be on the side of the patients that are having all these complications, which I just kind of felt was a little fascinating. And there's my resources or references, excuse me. And that's all I have.
Love it, Charlie. Does anybody have any questions about that? If I am talking to a future OR nurse, you guys will also be using the bear hugger quite a bit. They have some fancy ones in the OR. I remember one time I was a part of a mass casualty incident in the middle of January or something like that, and the anesthesiologist brought down like all sorts of different types of bear huggers. I was like, wow, I had no idea. All right, so Mackenzie.
Okay. Let's see. It looks like I'm screen sharing.
Yes.
Beauty. All right. So mine is on log rolling with C-spine precautions. I just have memes for interest since I knew I was going to be at the end of 2 long days of presentations. So there you go there. So provider or nurse driven. This one is like kind of dual initiation of C-spine precautions and log rolling can both be nurse driven, but clearance and removal is provider driven. So if somebody is coming in from an ambulance, from walking in, whatever, you as a nurse, if you're the first one to see them, should always be wondering if you need to put someone in C-spine precautions if they're not already in it. And then all the information that I got is pretty much directly out of CADLIC policies. So if you're not working at CADLIC, it'll probably be similar, but just look up your own policies. CADLIC uses the Nexus low risk criteria. So if you have any suspicion basically that they might have some sort of spinal injury or issue, you should pop a C-collar on them. You should the only reason you shouldn't do it for a trauma patient is if they exhibit all of the following criteria. So if there is no posterior midline cervical spine tenderness and no evidence of intoxication and normal level of alertness and no focal neurological deficit and no painful distracting injuries. So for all those reasons, if somebody's intoxicated, they might not feel an injury properly, so just pop a C-collar on them. And that's all nurse-driven actions right there. So the nurse's role, you need to maintain and initiate the C-spine precautions. You should coordinate a log roll when needed. Providers can be the person that is coordinating it, but a nurse can as well. You should be somebody that's either like holding the head in a neutral position or somebody that's holding the patient while you log roll them. A nurse can also hold a head in a neutral position until a C-collar can be put in place. Until then, other than holding manually, you can also put like head support devices like foam wedges or rolled up towels in place on either side of the person's head. And then another nurse role is knowing that the priority is expediting the time to get like radiological film or like a CT scan, because a C-collar, and especially if they're on like a backboard too, those are highly uncomfortable and a really high risk of causing impaired skin integrity. So if they don't need it, the sooner you can get it off, the better. How to do it. So these are 2 examples of definitely not how to put on a C-collar. It seems intuitive, but you could definitely mess it up. Application of a C-collar. So right here is really good, kind of step-by-step of how to do it if you've never done it before. When placing the cervical collar, you want to never like actually force the neck, and under no circumstances should the patient's neck be forced into a flexion or extension. Then you want to make sure that to fit it, you'll have someone holding the manual C-spine, and then you use your hand to measure at the shoulder, and then how many fingers to like the angle of their jaw line. And then you use how many fingers it is to measure on the C-collar where you should put it. most of the C collars look different than the one that I have on the screen right here, but they usually have 4 different settings: a tall, regular, short, and no neck. And so you adjust to that, and then you make sure that the big open hole, the big open hole that is over people's faces right here, you want that actually over like their trachea so that you can see their trachea and like view the neck. And then the little dip guy right here, that's where their chin should be resting, like so, like that. And then you want to make sure it fits properly. Usually a good sign that it fits properly is that they really hate it being on because it's really not comfortable. And then log rolling technique, there needs to be a minimum of 3 people, 2 people at the side, 1 person at the head. The person at the head is going to be the one that's initiating the log rolls. And then the kind of universal signs is that everyone, for the person at the head, say, everybody ready to roll on 3. 1, 2, 3, and you roll on 3, and then you hold them in place, maintain C-spine precautions along with spinal precautions the entire time you're holding them. And then the person at the head, when it's time to go back down, will see back down on 3, 1, 2, 3, and then go back down. The people on the side, make sure that you cross so that one person has a hand on the shoulder and lower hip, the other person has kind of behind the knees and upper hip, and then you roll them that way. Reasons you might need a log roll is to do a secondary survey of the back, remove the backboard, get clothes off, maybe do some sort of treatment on the back, but you want to keep on doing that and log rolling until it's been verified that they're clear. And that's pretty much it. That's C-spine precautions and log rolling. Any questions?
All right, thank you very much, Mackenzie. And inevitably, as soon as you get them in C-spine precautions, then they have to go to the bathroom. So
Yep,
sure
and then that's fine.
yeah, make sure you're using like a Trendelenburg type thing and a fracture pan and C-spine precautions with log rolling the entire time. Good job. All right, Michelle. Last one, yay.
Hello. All right, let's see. I think it's just that one. Can everyone see?
Yes, we can see.
All right, let's go full screen. It would help if I started on the correct slide. All right. So how to use crutches, basically. I know we went over this in first year, so I'm not going to get too into it, but the first thing you should do is make sure the fit of the crutch is right. The rest pad should be about 2 to 3 fingers below your armpits to prevent nerve damage. And your elbow should be slightly bent and hands should rest at the top of your hips. So when you're standing, the crutches should be wider than shoulder width apart and slightly in front for stability. I think they recommend about 6 inches diagonally in front of your feet. And you should bear weight when you're standing still on your strong leg and on the hands when moving. So you can kind of see it's called a tripod position that you're starting in. So safety first, use a gait belt so your patient doesn't end up like this guy. So there's a couple of different gaits. There's the 2-point gait where you're going to start in tripod, and that's moving the left crutch and right leg forward. And then you're going to move the right crutch and the left leg forward. So those move at the same time. The 3-point gait is if you just have one leg you can't put any weight on it at all. So you're going to start in tripod, but with the affected leg off of the ground. You're going to move both crutches forward and then swing your good leg forward and past the crutches. And you're just going to keep doing that. 4-point is starting in tripod. This is pretty much like 2-point, but you're moving each of your crutches and feet independently of each other. So you're going to move your right crutch forward, left leg forward, left crutch forward, right leg forward. And then there's a swing to swing through. They're both pretty much the same except for where you start. You're going to start in the tripod position. You're going to move both crutches forward and both legs forward. And for the swing 2, you're basically stopping at level with the crutches. But for swing through, you're swinging past your crutches and kind of just that swinging forward continuously. And the swing 2 is a little bit easier on your arms, but the swing through lets you move forward a little bit faster. And then as a bonus, I have stairs. I learned all of this pretty much from Nurse Sarah on YouTube, and she says good leg leads going up and bad leg leads going down. So basically, if you're going up, you're going to stand in front of a step, bear weight on the hands and boost the good leg up the step first, and then follow with the crutches and the bad leg. And then when you're going down, it's the opposite. You're going to move the crutches down first and then the good leg. And that's all I have.
All right, Michelle, great job. Does anybody have any questions? Okay, is anybody that got hired up into the like 9th floor or the unit so super glad that they are not going down to the emergency department? Raise of hands or or a thumbs up. As you can see there, the ER nurse is kind of a jack of all trades and a master of none. And if you don't like that kind of environment, then the ER is not for you. But you guys did an outstanding job of teaching each other some real basic skills and some life-saving skills. So I really appreciate that. Anybody have any questions, comments, concerns, feedback? Anybody found this helpful?
I really enjoyed that everybody else did the research for me.
Yeah, awesome. All right, well, I'll let you guys get to your other class. Thank you very much.